Yeah, thank you. Yeah, good morning, one and all, once again. Sorry for the interruption due to the internet problem. So today we are going to discuss about the biopsy. So this is a very important aspect where you need to, you know, understand, you need to diagnose the disease, and you need to perform this. And this is very essential as an undergraduate. One need to know what is biopsy, what are the different types of biopsies, what are the indications of biopsies, how do you perform clinically. Theoretically, it has been taught to you since third years, but practically you need to perform it, you need to understand it. Then how will you send it to the histopathological lab, and how the histopathological report you need to analyze and read it. So what is biopsy? Biopsy is bio is life, obsess is a vision. That is the biopsy is the removal of the tissue from the living organism for the purpose of histopathological examinations and diagnosis. So it is examination of the tissue removed from the lesion, and by extension the term is also used to convey the removal of the tissue. That is why the WHO. So any tissue, if you suspect any pathology is there, or if it is you are not able to come to the particular diagnosis, that tissue has to be submitted to the histological evaluation. So that is biopsy, removal of the tissue. The need for the biopsy is when the lesion is clinically suspicious. So we are suspecting some malignant lesion, benign lesion, or there is a confusion whether it's malignant or benign, or it may not be the pathological condition. To confirm the presumptive diagnosis made on a clinical and radiological findings. So we so usually the cases are diagnosed on a clinical and radiological confirmation. So we need to confirm it before plan for the surgical approaches. When the dentist cannot reach a definitive clinical diagnosis, to determine the treatment plan. So what type of treatment? Because the treatment plan depend on the histological report. Example, you want to do the surgical removal of or enucleation of periapical cyst or periapical lesion. So that lesion or dentigerous cystic lesion is there. So whether that lesion is dentigerous or OKC. So you need to understand it, which type of lesion is, or it is ameloblastoma. So the treatment plan differs from the different diagnosis. Then, to valuable self-teaching diagnostic kit, and to remove the cancer phobia. Many patients comes with any unhealed ulcers. They have a cancer phobia. So I must be having a cancer. So this is a need for the biopsy. Then medical legal record. So these are the indications for the biopsy. So any lesion that persists more than 2 weeks with no apparent etiological basis. So if any oral lesion is there, the patient is telling, yeah, since last 1 week I have this lesion, so you don't have to go for that. But if it is more than 2 weeks, you must advise that lesion or a swelling or whatever it is, it should go for biopsy. Any inflammatory lesion that does not respond to the local treatment after 10 to 14 days. So usually when there is any ulcer or any inflammation is there, the patient comes, you can start with the anti-inflammatory drugs, antibiotics, or topical applications of all the medications. After the treatment also, if it doesn't subside, then you need to go for biopsy. So you need to convince the patients according to this. Then the persistent hyperkeratotic changes in the surface of the tissues. Any persistent tumor suspected being a neoplastic. Inflammatory changes of a known cause that persist for long periods. The lesion that interfere with the local function. Example, fibroma, mucocele. So these are the lesions which you, or fibroma on the tongue, These are the lesions which usually interfere with the local function. Any lesion, in fact. Any tissue which is surgically excised, usually you should make that an habit of sending it for the histological examination. Any tissue spontaneously expelled from the body surfaces. Yeah. So this is important. Sometimes the patient may not be having any pain, but nowadays, as the COVID is there, you can see in many times the patients are coming with a mucormycosis or fungal osteomyelitis. In that case, the patients are taking analgesics, antibiotics, and after that, you will suddenly one time you will see that the patient has come out with a sequestrum or a bone which is there in their hand. So any tissue which is spontaneously expelled from the body, that also has to be submitted for the histopathological examination. Material from the persistent draining sinus whose source can't be readily identified together with the some lining of the sinus. So any bony lesions, they are not specifically identified by clinical and radiographic findings. Then any lesions that has the characteristic of malignancy. So these all things has to be, histopathological examination should be performed. The contraindications, wherever there is a poor general condition is there, but the main contraindication for the biopsy is the vascular lesions, hemangioma, arteriovenous malformations. So these things should be contraindicated. Blood disorders, acute, very virulent pyogenic infection of the lesion is present. So these are the contraindications for the biopsies. Yeah. So the biopsies you can categorize into surgical and non-surgical. Non-surgical is where you are not going to use a scalpel and remove the tissue and send it for the histopathology. So the non-surgicals are aspiration, there is a fine needle aspiration cytology, then the cytology, exfoliative cytology. So this exfoliative cytology will come in detail in the further slides. So these are the non-surgical modalities. Nowadays, it is also called FNSA and FNAB. Fine needle aspiration biopsy also is used, where the broad gauge or larger gauge needle is used for the aspirating the tissues. So fine needle aspiration cytology is also there. Fine needle aspiration biopsy is also there. The surgical modalities. So we'll just take that the surgically you take, hello, surgically soft tissue and the bone. Soft tissue, diagnostic and a curative soft tissue. So the diagnostic is when you want to do the incisional biopsies. So you can use the electrocautery. So then you can use a soft tissue curettage and frozen section. So incisional biopsy, what is incisional biopsy and excisional biopsy? We will discuss in the next slide what are the indications of incisional biopsy and excisional biopsy. So when you want to diagnose any lesion, so you will go for incisional biopsy. And when you want to treat that soft tissue lesion, if it is a mucocele or fibroma, you don't want to take it a diagnosis or an incisional biopsy because, or if it is a benign lesion, we want to go for a curative treatment plan. So that is by use of scalpel or cautery. And in a bony lesion, we have a diagnostic and curative procedures. Curative procedures are where you are going to periapical cyst is there or residual cyst is there. So you have already, with all the clinical features, you have come into a particular diagnosis. So in that case, you can go for enucleation, resection, or a curettage. So these are the treatment, curative treatment, and then you submit it for the biopsies. In a diagnostic cases, you can part of the lesion should be curettage. Trephination can be used. Small holes can be made in the bone, and then whatever the tissues are inside the bony window or in the lesion can be taken and sent it for the histopathology. Aspiration, frozen biopsy. So you can see the terminology in the frozen biopsy in two, soft tissue and hard tissue also. So what is frozen biopsy is where you are going to get the result immediately. These all biopsies biopsies, or you're going to get the result after 48 hours or 72 hours, because you need to fix the tissue, then you need to do the sectioning of the tissue, then you need to examine it under the histopathology, staining and examination. But in a frozen section, you do it staining immediately and you examine it. So these are the various types of biopsies: excisional biopsy, incisional biopsy, punch biopsy, frozen section biopsy, exfoliative cytology, fine needle aspiration, and brush biopsy. The surgical procedures usually, so once you identify the area or you need to do the biopsy, so adequate anesthesia. Usually most of the cases, these are performed under local anesthesia. Then the incision, achieving the hemostasis, surgical closure, and handling of the tissues or transferring of the tissues which has been removed. The excisional biopsy. An excisional biopsy, it is the complete removal of the lesion for the microscopic studies. Usually, the entire lesion with the 2 to 3 millimeter normal appearing tissue surrounding the lesion should be excised. And the excisional biopsy is usually done only for the benign lesions. Okay, so it is not indicated for the larger lesions. The lesion also should be smaller than 2 centimeter. So the advantage is you can have a diagnostic and therapeutic. So you are removing the tissue and sending it for histopathological examination. With that, you will come to know that, yeah, so what is the diagnosis? Then need to perform a separate surgery. No need to perform a separate surgery for the, once you have removed the small part of the lesion and you come to know that, yeah, this is a benign. Again, you should not go for second procedure. So the ones in the clinically you come to know that this is a benign, so you need to go for excisional biopsy. Indication should be employed with the small lesions less than 2 centimeter. Yeah, again, practically saying that it is not always that the lesion is less than 2 centimeter. We go. Sometime when the lesion is large, also more larger than the 2 centimeter, and you are confident that this is a benign lesion. In those cases, we do perform uh, excisional biopsy. So that is again depending on your diagnosis. If you are confirmed that it is a benign lesion, then you can directly perform and avoid second surgery in those cases. The lesion on clinical examination appears benign when a complete excision with the margin of a normal tissue is possible without mutilation. That is, so normal tissue, a complete removal of the tissue is possible without damaging or mutilation of the normal tissue. Contraindication, usually it's not contraindicated if the lesion is more than 2 centimeter. So this is a technique. So you give a local anesthesia and from the margin, yeah. So from the 2 millimeter around the margin, you remove the tissue in depth, then undermine the tissue and do the primary closure. So that is the excisional biopsy. Incisional biopsy is where the removal of just a small part of the lesion, and this includes the removal of the diseased part and removal of the normal tissue. So this is very important. So the normal part of the tissue also should be removed when you are doing the incisional biopsy. Indications: lesion larger than 2 centimeter, dangerous location of the lesion, it is very close to the nerve or vessels. So you want to see that whether it needs really the sacrifice or removal of those vital structures. Great suspicion of malignancy. Technique: representative area of biopsy in a wedge fashion. Margins should extend into the normal tissues on a deep surface. The necrotic tissue should be avoided. because necrotic tissues will not have any cells. A narrow, deep specimen is better than a broad, shallow specimen. Okay, so it should be narrow, deep specimen. We need to see the depth also. So usually you need to use a sharp blades and don't inject the local anesthesia where with the tissue you are taking the incision. So surrounding the lesion you should be injected to achieve the local anesthesia. So here you can do the so you can infiltrate around the tissue, but don't infiltrate in the where you are going to take the this thing. Uh, where are you going to take the biopsies? So do the incisional. It should include the normal tissue also. Then suture it. The biopsy of the intraosseous hard tissue. Intraosseous lesions are most often the result of problems associated with the dentition. There's a periapical surgery, amyloblastoma, periapical cyst, okay, dentition assist. Any intraosseous lesion that fails to respond to routine treatment of the dentition should be biopsied, and any intraosseous lesion that appears unrelated to the dentition. So what you need to do whenever you are doing an intraosseous lesion biopsy? Yeah. So one thing you need to understand that don't any intraosseous or radiolucent lesion on the radiograph should be first aspirated. Always think of worst. That is intraosseous lesion. It is not always, the cyst or a tumor. It can be hemangioma. So if you can use a thick gauge needle and penetrate and do the aspiration. First, aspiration has to be done before going for the biopsy. Use a trephination technique, then do the biopsy in intraosseous lesions. So punch biopsy, where the small part of the lesion is obtained using a punch. There are different punch instruments are available. So you use those punches and do the biopsy. Indications usually in dermatology, it is used. Mucosal lesions that can't be reached by conventional methods. That example, the lesions in throat or esophagus or pharynx. In those cases, it is used. Disadvantage, some amount of crushing of the tissue happens. So that is a disadvantage of punch biopsy. This is a frozen section biopsy. So what happens when you are doing any surgery, even in cancer surgeries or benign lesions? So we need to see that whether we have got all the positive or malignant lesions we have removed. And this is frozen section is needed when you are close to the vital structures, because if you are not getting the marginal clearance for the pathology, then you need to remove that vital structure also. So if you are finding a clear uh, non-pathological area, then you can leave that vital structure. So to diagnose histologically, you need to send the tissues when you are doing the surgery. Send that tissue, and that tissue is kept in a deep freeze section and then stained immediately and examined. So when you are doing the surgery, immediately that time only you will get the report whether you are achieved the successful resection of the pathology or not. If you are not achieved the successful resection, you can extend your resection during the surgery. So you get an immediate result in these cases. Fine needle aspiration cytology, where the aspiration biopsy is the use of needle and syringe to penetrate the lesion for aspiration. So it is usually done in cystic lesions of the soft tissues, most oftenly. That is in the neck swellings and all. It determines the presence of fluid within the lesion. Even in a bony lesions also, or any cysts of the odontogenic cysts also, you aspirate it. The aspiration can be done to understand the nature of the fluid. For example, if you aspirate and you examine the aspirate, there is dentigerous cyst and OKC. The clear straw color fluid is seen in dentigerous cyst. Okay, and the thick fluid or pus-like fluid is seen in OKC. So indication to determine the presence of fluid within the lesion. Then to know the type of fluid within the lesion, when the exploration of an intraosseous lesion is indicated. That's what I was saying. Whenever there's on radiologically, you will see that there is intraosseous lesion. You need to aspirate it first. So this is how you do the aspiration, and then you put it on the slides. There is a examination slide, and prepare the smear and check it after the staining. The advantages are obtain the cells from the sites of the body, and it's a less work is there than the biopsy. Fast, it permits the early treatment to start the treatment early. Can be done repeatedly for the on most masses or lesions. Enough material is obtained for the other studies also. So during the aspiration, but its disadvantage, it can be painful. It requires a great skill. Needle can damage the vital structures. Internal bleeding is possible when you're not aware about the anatomical landmarks or structures. Yeah, this is always a chance of dissemination of a tumor cells into the damaged vessels. But this aspiration cytology, it's not a diagnostic procedure. It is an adjunct to the biopsy. So only on the aspiration cytology, so you cannot do the advanced or resective surgeries. You need to have a confirmed histopathological report. This is a procedure where the mandibular cyst aspiration is done. Then the smearing is done like this, smearing on of the aspirates. Glass slide with the material obtained on the aspiration biopsy. Then after the smearing. Exfoliative cytology. Study of morphology of exfoliated cells under the microscope using a special stain. It cannot be used as a diagnostic procedures, usually used as an adjunct to the biopsy. Most commonly used stain is the PAP stain. Indications: mucosal lesions that appear clinically innocuous and otherwise would not be biopsied. And most of the time it is used for the follow-up patients with a prior diagnosis of pre-malignant and malignant mucosal lesions. So individuals who are debilitated in those cases to assess the oral candidiasis and